Anyway, thank you very much for attending. I'm Jill Rutter. I'm head of policy and employment support programs at Learning and Work. And I'm going to be chairing this session this afternoon. It's a very topical workshop because we saw the announcements in the autumn statement about expanding individual placement and support schemes by 50,000 people, and also expanding the places on the proposed universal support programme, which comes into operation in 2025 by another 50,000 places. So lots of focus on placements and lots of focus on employment support programmes for people with health conditions and disabilities. We've got 4 speakers this afternoon, and I'm going to introduce them one by one, and they'll speak for 5 minutes before we turn the discussion over to you for comments and questions. And we'll finish at 12:45 when you're very welcome to join us for the final session. So I'll introduce everybody and then hand over to Julie to start. So Julie's head of IPS at the Centre for Mental Health. She's also had a very varied career and worked as a counsellor for the NHS, for a housing association and a further education college in different roles. For those of you that don't know, the Centre for Mental Health is a policy advocacy organisation that works for better long-term approaches to mental health. Second, we've got Richard from the Shaw Trust. He's worked there for 11 years, managing employability programmes after a much longer career in employment support and training. And the Shaw Trust is a large charity that delivers employment support programmes for people with the greatest barriers to work. We've then got John Hall, who's a senior delivery manager for employment support at the West Midlands Combined Authority. And he's started his career as a coach, but also worked for lots of other employment support and skills organisations, from the DWP to Birmingham Local Economic Partnership and a number of independent employment support providers. Then last but not least, Dr. Jess Elmore, my colleague at Learning and Work, where she's the Deputy Head of Research. And she led a piece of work, an evaluation of the health-led trials, and she's currently leading an evaluation of the Restart programme. So those are our speakers this afternoon. So over to you, Julie, to start.
Thank you, Jill. Yes, thank you very much for inviting us from the Centre for Mental Health to come and speak today. We've been asked to speak around IPS. IPS is one of our passions. It's part of how we support people with mental health conditions back into work. So really pleased to be here. And as Jill said, we are a research charity. We are striving for fairer society, and part of that is a key element is paid work. So we're doing that by looking at evidence. When we discovered around IPS and the whole wealth of evidence behind it, it was something that we were involved in from the outset. So today I've been asked to speak to you about IPS. My role is head of IPS. 5 minutes is a huge challenge for me. So if I speak a little quickly, please bear with me. But I thought it was really important to talk to you today around some of the key aspects of the IPS model. So for those of you that aren't familiar, I will be looking at high level, what is IPS? looking at some of the evidence behind IPS, and then talking about how IPS has moved into new populations. So IPS, what does it stand for? IPS stands for individual placement and support. Quite simply, we work with an individual, we place them into a good quality job, and then we support them to stay there. So the model itself is broken down into 8 key principles. The first one is that we are supporting people into competitive paid employment. So employment that is open to anyone to apply for, so not set aside employment. The next bit is, this is key in health settings, is that everybody is eligible. So everyone who expresses an interest in working should have that opportunity, irrespective of their health diagnosis. So that should not be a barrier to itself. The job search is consistent with individual preferences. So we go out looking for jobs that suit people in terms of the type of job, the environment they want to work in, the type of hours. So really thinking about what's going to be important for that individual to have a good quality job, but also that sustainability factor. We know from our research that one of the key success factors in employment is motivation. And we want to work with people when they express an interest in work with that motivation and support people. So job search is rapid. So the model is what we call a place then train model. So really thinking about getting somebody into work and then looking at the support they need to sustain work. The fifth element of the model is that employment specialists are integrated into treatment teams or clinical teams. So the model originated in mental health services, so secondary mental health services. So originally the model was looking at community mental health treatment teams. As a model is being adapted, we're looking at other treatment teams. So it could be in primary care, talking about GP practices, and also drug and alcohol treatment practices as well. So whoever the people are supporting the individual with their health condition, really thinking about how we can support that individual, not in work, but also some of the barriers that may arise from their health conditions. The other key factor is that we support people for as long as they need it to be. So very much thinking around being there to address any of the issues that they may face, or supporting the employer. So it's time unlimited, and that is a key factor in the IPS model. The other aspect is we want people to feel that work is valuable, and part of one of the biggest barriers to people going back to work is a fear of losing benefits. So what's really key here, and one of the founding principles, is that we look at the impact of somebody returning to work. Are they better off in work? So really upfront looking at doing a back to work calculation, so the person is really informed about what work will do in impacting on their benefits. And the 8th principle was a last principle added a bit later on, and that was talking about employer engagement. So really going out and developing good quality relationships with employers, supporting the employer, doing job carving, trying to get that good quality job that meets the individual's needs, but also meets the needs of the employer as well. So really thinking about what employers want. Why do we promote this IPS model? We promote it because there has been a huge amount of evidence. We believe it to be the most research-supported employment model out there. There are 28 random control trials internationally. This graph shows you the results of some of those trials. The black bar being people that were supported through the IPS model. The red control group, so people that received additional employment support, additional quality employment support, but not IPS. And as you can see, the average results show that the IPS supported employment model is twice as effective as other supported employment models. So it's not saying that other supported employments don't work, it's saying that IPS has much better outcomes. So one of the questions that people often ask is, well, is it just about a job outcome? No, we know from research that there are added benefits for people being in work. we've found out that people have fewer hospital admissions, and if they are going back into hospital, they have a quicker recovery time. The results, quite often people say, well, does it matter where it is? You know, our part of the country is very rural, our part's very urban. No, it doesn't matter at all. Through the international research, we found that local economic factors do not change conclusions. So it doesn't matter which country, doesn't matter around you know, the area, whether it's rural, whether it's urban, whether it's semi-urban, local economic factors do not change the conclusions of the research. We also know that IPS schemes have lower dropout rates. We think that's because we're working with individual preferences. We're doing a lot of motivational interviewing around supporting the individual to think about work. And also the outcomes are not just about employment outcomes. It's not just about numbers. We're getting people into work quicker. We're supporting people to do more hours per week, and they stay in work longer as well. And it's not only the benefit of being back into work, we know that people have better personal outcomes as well. So the evidence has showed that people have increases in their self-esteem, in their relationships, and also in their personal management of their illness as well, which obviously has knock-on factors for the economy as well as the individual. And just briefly to say that the research has been so great with IPS in secondary mental health that it's been rolled out into other areas as well. So we have IPS working very well in addiction services, and there's additional funding to roll that out. So we know that by 2024, 2025, IPS should be available in all drug and alcohol treatment services nationally. We're looking at IPS in primary care. So some of the health-led trials around that has been really effective. And we're looking at new populations as well. So one of the new populations we're looking at is how we support people in the homeless sector. We've come on a huge journey in IPS in secondary mental health, and we're sharing all our learning with the other new sectors as well. So really happy to have lots of questions from you around IPS in any of the sectors, not just mental health. Quick overview, really, hopefully I've covered that briefly in 5 minutes. Thank you, Jill.
Take the slides down and hand over to Richard now for his presentation.
Thank you very much, Jill. I'm Richard Clifton, Chief Commercial Officer from Sure Trust. Sure Trust is a national charity, and we've been working with supporting people with health problems and disabilities into employment for over 40 years. And we've run a range of contracts, and most of the main contracts through DWP, and working with a range of local authorities and within health as well. Sure Trust is, building on the IPS theme, is one of the largest providers of IPS in England now, and that's grown significantly for us over the last 5 years. Sure Trust originally entered sort of the IPS market, although we were doing a lot of work within employment support in general, around 5 years ago when we launched our Aim for Work contracts in London, and that was part of the BBO contracts, ESF and Big Lots funding. That we actually achieved the IPS Centre of Excellence in 2019. We're also very involved in the early pilots of the health-led trials within primary care that Julie was talking about, and we delivered one of the 3 of those in the West Midlands. Sure Trust now has 3 IPS services that we deliver within secondary care, 4 that we deliver within primary care. So we have deliveries now across London, in Kent and Medway, Birmingham, and most recently in South Yorkshire. We've also looked at how we integrate key elements of sort of the IPS principles within other programs, and I suppose most notably at the moment is the Work and Health Programme Pioneer, which is being used as a bit of a test bed for universal support moving forward, and we're working with DWP on that. I suppose for me, some of the key learnings that we've gained from delivering IPS in particular, but other supported employment programs, is that engagement and informed choice at the start of the program is so key to the success. And I think this is something that we do have to really think about with universal support coming out and having referrals from different route plans. Actually building up that rapport at a very early stage, as Julie said, making sure that we are taking on board the choices of the individual and gaining their motivation through the program is absolutely key to the success of maintaining engagement and moving them into employment. I think what we've seen is, really backing up what Julie said, performance on IPS is really, really good, and compared to other programs we run is higher. So we do look at least 40% job outcome rates on our programs across the board, with at least 70% of those going into sustainable employment. And I think the other bit that surprises people is also things like the average salary. At the moment, we've just done a check on that over the last 12 months, and the average salary of people in employment is nearly £30,000, £29,524 as an average salary. So we're looking at good jobs that people are going into for sustained periods. So it is very good from that perspective. And the same on the hours. People are actually on average getting around 21 hours of employment that they're moving into from the program. So it is a very successful program in all of that regard. I think the bit that I would caution in some respects is that we have seen people trying to do a little bit of a pick and mix of the model, and you can't just take bits of the IPS model. You do need to stay true to the model itself. There are things you can learn from it and apply, but I think we'll be careful saying that that is an IPS model. I think it isn't a pick and mix. I suppose that just ends really with some of the challenges that we're seeing, and some of those are around devolution, although there is so much benefit from devolved models, and particularly within the integration within health and local communities and the targeting support to the right groups. We are now seeing that that is leading to some complexities from a provider perspective on how we're actually bidding for and contracting for the work. So we're seeing differences between PBR models, grant-funded models, and different targeting in different areas. What we've got to be careful is that that doesn't end up leading to more management costs, because we are having to have different approaches in different parts of the country. I think the final bit, I suppose, that I would land on is universal support, as we are trying at the moment, isn't necessarily a true IPS model. And we are looking at that it is a place and train model, but it isn't the full IPS model. And I think we've got to look at, as we move forward with that, how can we make the most of what we've learned from what we've done to make universal support as successful as possible. More than happy to take questions afterwards, but that's a short summary from Shore Trust's perspective.
Thank you very much, Richard. Over to John now from the West Midlands.
Good afternoon, everybody. My name is John Hall. I represent West Midlands Combined Authority as one of the senior delivery managers based on around employment support. I suppose what I'd like to talk today is actually build on the two contributions that we've had from Richard and Julie, and just talk around our Thrive experience and also kind of the impact in terms of the wider ecosystem in which I suppose we're trying to influence to support the integration of IPS models. So West Midlands Combined Authority was very much kind of enabled to start our IPS journey back in 2018 in terms of our Thrive Into Work programme. It's something that we're very proud of, and it supported 1,000 of our residents into work over that period. And we've had the opportunity through the pilot to go through various iterations. So in the first iteration of it, it was focused on those individuals who were who were unemployed, and we had the opportunity to work with Maximus, Shore Trust Group and Black Country NHS, so having very different partners in relation to supporting us with that journey. And as I say, within the first wave, it was a brilliant opportunity to do that. And then as we've gone through the second and third iterations, it's then allowed us, as kind of Julie noticed, for us to actually go and look at different cohorts of individuals in terms of how the IPS model can support those individuals who are employed, those with neurodiverse challenges, those that are homeless, and those also at risk of offending as well. So it's been, as I say, a really interesting journey to look at how that IPS model flexes and works with those varied cohorts as well. And the other thing that we've really looked at in relation to this is how we can integrate IPS as part of this journey. And we've piloted fit note trials working with doctors' surgeries over for those of you that know the West Midlands region, across the Black Country, so 4 of our local authorities, to look around how we can kind of develop referral processes with primary care to actually ensure that IPS supports the right individuals, or those individuals that require that support. There's a whole host of varied employment support opportunities out there. And I suppose one of the challenges we face is how we make sure that those that utilise IPS, it's the right fit for those individuals in terms of how we take them forward. Some of our key learning that we've had from our provision, I don't know if this is will be a surprise, but what we've seen is that actually through Thrive Into Work, that 22% of those people have engaged have been 18 to 25, and 24% of those have been 26 to 35. So we've really seen kind of the younger individuals kind of engage with this programme and be supported. And what would come as no surprise is that a lot of the the health conditions that relates to is there's been increasing proportion of those with mental health concerns and equally physical health as well. And I suppose as a progression route for those residents, we've probably seen 25% of our customers who have moved on into work have actually moved on to work in the health sector themselves, which is, as I say, shows an interesting piece of alignment. I think just in relation to the final, I suppose, 2 minutes, I just wanted to reference, I suppose, some of the challenges that we are faced as a combined authority in relation to the journey. In relation to IPS, is that the fact now we've got a far more, health has become an increasing priority, quite rightly, for a whole host of different government groups and organisations. So we've kind of seen, I suppose, the UK SPF move into a world of looking at inactive people with health conditions. We know that obviously we've had the Pioneer extension and universal support. And equally, in terms of work well and looking at kind of what that triage approach has, can bring as well. And I think it's really important that regionally we look at the level of alignment that we have and how we can properly support those opportunities to kind of integrate. And as I say, it's about how we can make sure that there is, to support referrals, kind of one front door, and that we can then actually support how we can connect our residents with some of those opportunities. And I think the work well piece, I think, is a really interesting opportunity to look at triage and how that might play out. But I think one of the things, particularly around primary care, that we're very much aware of is that we know from history of welfare to work and how confusing our wider offer is for employers. Well, actually, we've now got a risk in relation to because of the different contracts and funding, potentially chasing those people who are inactive with health conditions, around actually the articulation of what our offer looks for those primary care or socials prescribers that may want to refer their residents into this opportunity. So I think there's a real onus on us all in terms of making sure that we have an aligned and a transparent offer that utilises all of those levers that we'll have in relation to supporting our residents with health conditions. Hopefully, Jill, that's within the 5 minutes.
Perfect. Thank you, John, for keeping to time. So our last but not least is Jess, who's going to focus on the evaluations she's been involved in.
Thank you. So I'm going to start by taking us back to basics a little bit, just to talk about some of the gold standard evidence that L&W have collected around what works to support people with health conditions and disabilities. And then I'm going to focus in on work as a therapeutic outcome and how we've observed this in our evaluation of health-led trials. So a summary of what works. We know that we need specialist programs for people with health conditions and disabilities. It's unlikely that someone with a more severe health condition can be supported within a mainstream program. As all the previous speakers have identified, we know IPS works really well, but equally, we know that it only works if fidelity standards are observed. So there are lots of other good employment support programs, but IPS delivered to fidelity standards has very clear, well-evidenced outcomes. Against this, we also know that supported internships work well for people with learning disabilities. So rather than the competitive employment model used by IPS, for this particular group, a supported internship can be a good route into employment. Another really important key learning is that early intervention to stop people leaving the workplace with a health condition is much more effective than support to return to work. So support for people who are out of the labour market, really important, but getting to people before they leave employment is essential. And as John identified, that's something they're looking at in the West Midlands and also something in South Yorkshire. We know that integrating health and employment services support getting people back into the labour market. The evidence on how we do this is actually much more limited, and I think that's a really interesting thing for us to discuss, is how do we integrate health and employment services, because it can be a real challenge for many employment support programmes. We also know that awareness and skills training for employers and health services, again, will support early intervention that prevents labour market exit and keeps people in work. But again, getting to the right employers, to the right health services to deliver their training they need is not as simple as the evidence that it works. Finally, a lot of evidence in the UK is based on supply side programmes, and we have much less evidence on demand side. So we know that access to good jobs is fundamental to any employment support programme, but we know much less about how to encourage employers to open up real opportunities for people with health conditions and disabilities. So we think about access to work. There's not been any impact evaluations of that. There's limited evidence of the disability confidence scheme. There's limited evidence of the value of financial subsidies. So what I would say, it's very important to discuss employment support programmes, but we also need to be thinking about the demand side. I'm going to switch a little bit now and talk in a bit more detail about work as a therapeutic outcome. So this is quite an abstract concept in some ways, but I think it's actually at the heart of what we're trying to do when we're researching employment support and when we're running employment support programs. It means that people are experiencing improvements in health and well-being as a result of being in work. And as we observe this in health-led trials, there are a number of contexts that needed to be in place for this to happen. So first of all, what does work as a therapeutic outcome mean? Well, it means people are experiencing improved confidence and mental well-being as a result of being in work. It means the financial benefits of work are leading to improved health and reductions in stress and anxiety. And it means that people are experiencing improved well-being because they've got the opportunities to use their skills and progress in their careers. However, in order for individuals to experience this, a number of conditions needed to be in place. They needed to have a job that was right for them, which is one reason why IPS is so useful, in that it's designed around getting the right job for somebody rather than any job. They also needed to have a health condition that wasn't exacerbated by working. And I think this is really important in the current context of employment support, that IPS is open to everyone, regardless of their health condition, but we need to recognise that some people are not able to work, and we need to recognise that those people need to be supported. And finally, individuals needed to be motivated to work, not just for financial reasons, which again, I think is quite important in the current context of looking at increasing sanctions or withdrawing benefits. Actually, what we need to be doing in employment support programmes is motivating people to work for the right reasons, rather than motivating them out of fear or out of financial insecurity. I am going to leave it there. So we've got plenty of time for our discussion, but I'm really happy to talk about any of those points in more detail.
Thank you very much, Jess, and thank you for kind of giving a sort of comprehensive overview of the different types of intervention. So I'm going to kind of start by asking if anybody has any kind of questions that they wanted to ask the speakers before we move into a discussion. I don't know if anybody wants to kind of flag up questions in chat. Whilst we're waiting, I've got a question for the speakers. Civil servants are kind of beavering away at the moment, designing the universal support system. We know that there will be some kind of cutting of corners. If you were kind of asked to give kind of one piece of advice for those delivering planning employment support, what would that be? What do you want to tell civil servants at the moment? Shall we start with Julie?
So I think it goes back to support in different ways. It's all really important. Thinking that particularly the bit about it's easier to keep somebody in a job than get a job. So really thinking about key to have really good early interventions and a lot of support for job retention services as well. So keep job retention for specialists, but then support people who are out of work via IPS. That would be my one key thing I'd like to say.
Great. Richard, do you want to come in?
Yeah, I think it's going to come a little bit back to what I said in my remarks. The key bit for me is actually getting that early engagement and informed choice right for the individuals. I suppose it builds a little bit on what Jess has finished off with. People have got to be joining for the right reasons and be informed about what they're doing. I think if we end up with a programme of people being forced into it for other reasons, then we won't get the outcomes that we want. So I think allowing providers to actually work with people prior to formal referral, so we make sure that they're well informed before they're referred onto the programme, is really important. We know with all DWP programmes, even though we say they're voluntary, as soon as somebody has been referred and started, they are in the programme and it's difficult to get out of it. So I think from some respects, getting that initial bit right, and I suppose it builds a bit on what John was saying about getting people onto the right programme at the right time and not having confusion, I think is the important bit.
I've got a bit of a follow-up question to you, John. Sorry, Richard. In that the government said it essentially wants 100,000 more placements by 2025. We know that the kind of quality of the placement is really important. How do you think we can expand the number of employers who are willing to offer placements?
I think linked to university, if we were to do that, we've got to do a lot more work with employers. I think as Shore Trust, we have a national accounts team and also regional teams that work with employers. And we probably go that bit further than disability confident, because we would call what we do as sort of like disability confident plus, of actually working with them to get better understanding of how they can be more accessible and offer opportunities in a way that are supportive of people that have different needs. But it is going to be a challenge. If we're talking of the numbers that they're talking about, we are going to have to do a lot of investment into that work with employers to get this bit right.
Great. John, what's your top tip for DWP?
Thanks, Joe. I think as someone that's been involved in some of the discussions with DWP around this, I've probably got a long list of tips that I've hopefully tried to share with them. I suppose the piece for me is just around flexibility within the journey. And I think sometimes, Judy mentioned right at the start regarding the time-bound nature of and it not being time-bound. And I think there's always a risk in relation to how that's facilitated through universal support, as actually when we were working with people with health conditions, particularly on a voluntary basis or even on a mandatory basis, there will be times within that journey where there may need to be a stop and there may need to be a break. And I think sometimes within some of our provision, we don't give our residents the opportunity to pause. And because I think often when we're trying to support people into work, the gold dust isn't necessarily the intervention that's given. It's actually that epiphany that the individual has in their own mind in terms of that they've decided that working is right for them at that point. And I think for me, this is really around allowing our residents time to breathe within some of that provision. I think often what might happen is you reach a point where something's delivered, and actually, if it's a 12-month program, only at kind of 10 months might they have that epiphany because it's taken that time to get there or whatever happens in their personal life to do that. And I think it's that opportunity to let the interventions happen at the right time for the resident. And if someone needs a pause, let them have the pause and then let it continue at a later stage. Appreciate that's harder to manage from a DWP perspective, but I think we'd see greater performance or greater results as from that kind of methodology.
Great, Jess, what's your tip?
So quite hard to choose one, but I think just to mention something that hasn't been included before is the importance of the employment advisor. So in every single evaluation, the role of that individual providing personalised, skilled support, working with an individual, motivating them, encouraging them is absolutely crucial and absolutely central. So it's about how do we recruit these staff? How do we retain these staff? How do we make sure they have low enough caseloads to actually support people in a meaningful way rather than having 50 people to deal with? How do we keep those caseloads down? Because that is the evidence from people in employment support programs is that one-to-one support is what achieves outcomes.
Great, thanks. And I think you raised a really important point about coaches and about specialist coaches. Our work in this sector is, it's typically kind of quite insecure. People move from kind of contract to contract, and there isn't always a kind of career progression. So kind of developing coaches as a profession, I think, is quite important. We've mostly talked about IPS today, but the DWP is expanding its youth hub initiatives, and some youth hubs involve health interventions as well. And in the West Midlands, I don't think I'm kind of betraying any state secrets. The West Midlands Combined Authority is looking at expanding its adult hubs across the region, and these potentially are able to kind of link into health advice. I don't know. I'm quite interested to find out kind of a little bit more about what is effective multi-agency support, wraparound support for people with health conditions. And I'm going to come to Richard first, because I know Shore Trust has been involved in this area. What's effective in terms of wraparound support?
Actually, I'm probably going to reiterate what others have been saying. I think it is having either a no wrong door or a single front door type approach, so people get to access the support they need when they need it, but also embedding teams together and having close working, I think, between employment advisors, health professionals, but also more broadly within. So if I look, with work we're now doing, we have been doing in Birmingham, we're now doing in West London, actually now bringing in more of the local authority services in alongside the health services, and actually building up packages of support and working together around the individual. That can only be done, and we're going to keep reiterating, with small caseloads, with one-to-one support, so we make sure we actually guide and support people through that. And I think that's the key to it, is actually that individualized support. Everybody is different. There is no one route way that is going to work for everybody. That flexibility is going to be there, and to achieve that, you need the integration and be able to work with different organisations, different statutory bodies, local organisations, to actually build the support that somebody needs. And then let the individual build their own network of support. So that's then long lasting once they've moved into employment, that they don't always need the employment advisor there, although they can access our support for long periods. Actually, it's better if they build that network of support and know who they can go to get the support when they need it.
Fantastic. Julie, do you want to kind of contribute here?
Well, I was just sort of wanting to support what Richard said. You know, some of the barriers to effective working are around, you know, data sharing between organisations. Thinking about the individual that I've worked with in the past that have said, I don't really want to go through another assessment. I've had to tell someone this in this organisation, that organisation. So there's something around trying to remove the barriers. And just, you know, people that traditionally might have fallen between. So perhaps somebody on the autistic spectrum might have said, well, they're not mental health, they're not learning disabilities. You know, who is going to be there to support? So trying to remove all of those barriers so that people get the effective support when they need it. And yeah, so that no wrong door bit, that we'll just open it and be able to share information, I think.
Great. Jess, do you want to say anything here?
So I think the integration of health into employment support can be a real challenge. And I think, as Richard and Julie said, I think it needs to happen at a strategic level as well as at an individual level. And so there needs to be real consideration of who are the best people to go through with healthcare organisations. So I think, as Julie mentioned, data sharing can be a huge problem. GPs can be absolute blockage for employment support programs because they are completely overloaded. Trying to get into the door of a GP can shut down any kind of, so it's thinking about where else could you engage. So going through an occupational therapist, going through a physiotherapist, those people have longer appointments and have more time, can provide a way in. Equally, co-location is the gold standard, absolutely works really well. Again, not always easy to achieve. So it's recognizing where can you have a maybe halfway location. So someone goes and spends an afternoon in a GP's office rather than expecting to go through that full data sharing. So I think it's being strategic and having that big oversight, but also being realistic about what you can achieve.
Great. So we're almost at the end. And I think some really interesting learning today are a range of programs, a range of different approaches. I'd like to thank Richard, Julie, John and Jess for their contributions. And Lucy, our host, has just put the link up back to the main session, and it would be fantastic if you could join us. But thank you very much for your insights this afternoon. Thanks.